Today we have Dr. M.S. Hiremath sir with us, who is Director of Cath Lab, Ruby Hall, Pune. He was also a past president of CSI and earlier chairperson of NIC. He has a session on when to revascularize after OMT, optimum medical therapy. So, sir, I request you to have a beautiful discussion on this, like how the things proceeded right from 2000 to current 2019. So, sir, during 2000, it was an opinion that intervention is better than medication therapy. So, how would you?
Yeah, actually, it's quite a pity that both surgery, the bypass surgery, and the angioplasty are more than 30 years old, and we continue to argue which is good for a patient. On one side, the revascularization, either with bypass or with angioplasty, and on the other side, medical treatment. As you mentioned, Dr. Rahul, in around 2000, there were lots and lots of studies which clearly indicated that if we do an intervention, patients' lives are saved, myocardial infarctions subsequently are saved, and overall patient lives a healthier life, angina-free, medication-free, and thus is more functionally effective. So not many argued, and that's why the number of angioplasty as well as bypass surgery, that's the revascularization, continued to grow. In came Courage, a big study in 2006, and in 2006 the study indicated that the medical treatment, optimal medical treatment, could be equivalent to angioplasty results for patients in short term as well as long term. In fact, Courage 15 years is also now available, and it says that there is actually no difference. One finally concludes that putting stent is at least not harmful to the patient. That's
right.
what the long-term conclusion of 15 years of Courage. The Courage was actually most of the time two-vessel disease or one-vessel disease. It was also criticized for a few reasons. The results of optimum medical treatment in Courage were absolutely outstanding. Most of the registry data indicates that LDL reduction to the target, which is generally less than 70 for secondary prevention, was 95% and more for Courage, while for conventional registry, or what you and I practice, is just around 50 to 60%, at the most 70%. So LDL reduction was outstanding in Courage, and everything else too, like usage of beta blocker, usage of aspirin, blood pressure control to less than 130 was outstanding in medical treatment. But a similar effort was not taken in the other group, the intervention group. Like, two-vessel disease was more than 70% in Courage, and I would imagine that all should have got at least two-vessel stent, if not more.
Right.
But only 36% of these cases got a two-vessel stent. Others probably were left alone for medical treatment, or maybe just a balloon dilatation. So this was one. So angioplasty was not done very well. All patients or all lesions did not get stents, and also the drug-coated stents percentage was very, very small compared to what we use in daily practice today. So Courage had lots of flaws. However, it still indicated that if your quantum of ischemia was more than 10%, intervention arm looks better than Courage. So Courage, many people say that it was no to angioplasty. It's not true. It is still that if ischemia was sizable, angioplasty could be giving you better results, especially on symptomatic benefits and reduction in number of medication. So in general, if I have a younger patient who is very dynamic, very active, I would probably finish him up with PTCA, then wanting him to come back again and again with sort of complaints, follow-ups, repeated tests and so on to see if any lesion is growing further. So this was the issue with courage, that it indicated a big way that medical treatment could be very effective compared to PTCA. Things moved on, and this sort of balance of studies continued, and we had advances in both areas. Angioplasty was also getting better, and medical treatment was also getting better, including introduction of evolocumab, which got LDL down to something like 25% or less. So all these were happening. So overall, the reduction in event rates for both the invasive arm, revascularized arm, and the medical arm were always going to be less. And since courage had these shortcomings, in came an ischemia study, which was presented last month at the AHA. And in this study, all the flaws which courage had were corrected. In ischemia study, the documentation with stress test, stress echo, stress thallium was moderate or severe in majority of the patients. Something like more than 75% has major ischemia. Also, they had sizable coronary artery disease, and yet they were managed with medication arm and revascularization arm. So we expected, as the standard thinking goes, that revascularization arm would save and come out winners in these cases. However, it did not happen. I think to a little bit of dismay to the intervention cardiologist and the bypass surgeons, the ischemia study did not show aggressive benefit with an intervention arm. It, however, indicated, or it actually excluded a certain subset of people, like people we know who have low ejection fraction and multivessel disease, like less than 35% with multivessel disease. Stitch trial had clearly indicated earlier that surgery is clearly better than medical treatment. This group was excluded. Patients who had ACS inside 2 months after initiation were also again excluded. Left main or proximal LAD, orchial LAD were excluded. So these are some areas where we say angioplasty is a must, but they were excluded. So I would imagine that though the quantum of ischemia was a key issue in majority of earlier studies, and they were included in the study, the important subset where we do a bypass or an angioplasty were taken away. Ischemia to me comes as a little bit of surprise, and I'm sure to many interventionists too. However, we have to respect the study data, which was sort of, it's a modern age angioplasty and modern age bypass surgery. So majority of the patients got stents, majority had multivessel stents, majority had very good drug-eluting stents, and yet the benefit was not great. What it reduced, again, pretty similar to courage, is the angina threshold was much higher for these intervention group compared to medically managed group. Also, the number of anti-anginal medications were much less. So somebody who is traveling out frequently, very dynamic, again, similar indications, I would probably feel that revascularization will hold benefit. But remember, the exclusion for ischemia study were quite important, and we should not treat those as stable coronary artery disease patients. Again, the question comes, after an ACS, after 1 year, does the patient become stable, and can we treat him as a stable coronary disease patient and include them in this kind of group? The answer is no, because there is a clear documentation in some of the major studies from Europe, which and continue to indicate that once an ACS event has taken place, second year, third year, fourth year, the probability of a repeat event is always there. Probably it increases as time goes, and this is happening from the non-culprit areas in the coronary tree. So we need to sort of keep a very close watch and make sure that whichever are important, we should handle them with angioplasty. Here comes an important issue of adding physiology to the intervention, what I can call as a smart angioplasty. So you use FFR. So many times you see 3 vessel disease and you feel that patient should go for surgery. So you do FFR and probably 3 vessel disease becomes 2 vessel disease. So do 2 important arteries, do an angioplasty, the third one you conserve, and patient would probably get benefit. This is seen in FAME-1 study as well as Syntax-2 study. In Syntax-1, if you see a medium or higher Syntax score, the gap between bypass surgery and gap between angioplasty was quite a bit. Syntax-2 was done with physiologic testing, and that's why the gap is narrowed. So angioplasty can be as effective as bypass surgery in terms of revascularization in moderate Syntax score. But we are not talking of that today. We are basically trying to see who can be managed with medication. I think the good news is that a lot of patients who have sizable ischemia but doing reasonably well, especially in elderly, can be continue to be managed with medication. And angioplasty or bypass surgery could be reserved for a certain subset who are likely to come back with something acute. Now, my own feeling is handling a case during acute setting is far more complex compared to somebody who comes as a stable case. Also, the completeness of revascularization was not mentioned in ischemia study. To me, completeness of revascularization is extremely important. If you are revascularized completely, your event rate is here. But if you do partial, your event rate in following years could be here. And if you do an incomplete job, your event rate could be even much higher, sometimes 3 times more compared to complete revascularization. So completeness is a possibility under stable settings, and I would feel that we should not lose an opportunity to revascularize when patient is stable and giving you enough time to plan a good future for him. Also, the stable angina is never stable all the time.
Right.
You know, there are in between episodes of unstable angina, myocardial infarction, and more importantly, multiple small myocardial infarctions, SMI. And all these can actually lead to LV dysfunction. Once LV dysfunction goes beyond a point, revascularization may or may not help. So you should not sort of wait for the LV to go down. So to me, a stable angina, doing well, good enough to put them on medical treatment, but keep watching his LV function. Keep watching the quantum of ischemia during follow-up, say every 2 years or every 3 years. If either of them is suggesting that the patient is likely to benefit with revascularization, still go for it and not stick to medical treatment all the time. So as a follow-up for about 4 to 5 years, we could conclude that this medical treatment can be quite effective. But always remember, once you diagnose coronary disease at the age of 50, which most of the time in India we do, you have to think of next 30 or 35, 40 years. So based on that, I would probably keep following these patients on a regular basis and intervene at an appropriate time and not leave them for medical treatment though they are deteriorating. So to me, an intractable angina, limiting angina, like a young patient, for a young patient, the angina is not, it's a nuisance. It's not allowing to do his office work regularly.
Right.
I would still consider revascularization as a possibility. But the good news, especially for our elderly CAD patients, stable, is yes, you have medical treatment as a very good option. Most of the time, husband and wife, just two of them living together, they're extremely scared for an 80-year-old to go for a bypass surgery. I think ischemia study is really good news for them.
Right. So, sir, as I understand, you beautifully simplified the journey of 2 decades, right, from 2000 to 2019. So, it was a pleasure listening to this session, sir. And I also hope many of the audience who had various concerns and doubts might have got cleared and from this session and might have got help. So,
in fact, you know, as I interact with many people here, because ischemia study is just a month old or maybe less, and people are sort of having big question marks as to what is going to be the future.
right.
As time goes, we sort of sub-analyze these major impact-making studies, and I would still feel that some subsets would emerge where intervention arm would still continue to be a stronger arm compared to medical therapy.
Right. So, thank you, sir, for beautifully summarizing the whole session, and thank you for your presence over here. Thank you very much.
Thank you.